Daros la bienvenida en nombre de la Fundación ALPE a todos los asistentes. Bueno, para los que os unáis por primera vez, yo soy Susana Noval, soy la coordinadora de la Fundación. Con nosotros también está, aunque no la veáis, Carmen Alonso, la directora, evidentemente, que os da la bienvenida. Estefanía González, que es la directora de proyectos, y Sonia Sestelo, que es la encargada de todo el tema administrativo. Presentar también a Laura Ordóñez, que es nuestra traductora incondicional, amiga y colaboradora de la Fundación, que siempre está en nuestros congresos y también en nuestros seminarios. Bueno, como sabéis, un poquito, esta charla forma parte de un ciclo de charlas que nosotros hemos denominado ADEE Expertos. Para los que no estéis muy familiarizados con este acrónimo, utilizamos ADEE pues, para hablar de acondroplasia y otras displasias esqueléticas que causan enanismo. Bueno, hemos decidido pues, ya casi hace más de un año utilizar este acrónimo para abarcar todas las displasias esqueléticas que causan enanismo, no dejarnos ninguna. Y quizás también para hablar de ellas, quitar pues esa connotación peyorativa que a veces se utiliza a la hora de usar los términos relacionados con el enanismo. Entonces, bueno, nos referimos a personas con ADE o a ciclo de expertos en ADE, porque, bueno, no es oficial, es verdad que es oficioso, pero creemos que da buen resultado y que es positivo. Entonces, en este ciclo de expertos ADE, bueno, pues se trata de un poco lo que siempre explicamos, intentar divulgar conocimiento, hacerlo llegar a todas las personas con ADE, sus familias y a los profesionales que trabajan habitualmente con ellas, ¿no? ¿Por qué? Bueno, pues porque como están enmarcadas dentro de lo que nosotros o de lo que se denominan enfermedades raras o poco frecuentes, que nos gusta más utilizar ese término, a veces hay poco conocimiento y a veces el poco conocimiento que hay es poco accesible o bien para las familias y para las personas o incluso para los profesionales. Entonces creíamos que era importante realizar este ciclo de charlas para de verdad hacer llegar ese conocimiento, esa divulgación, ese conocimiento del manejo clínico de las ADE y bueno, pues también las buenas prácticas, que también es importante, ¿no? Bueno, también desde una perspectiva integral, quiere decir que abarcaremos temas clínicos, que se abarcará también, como ya se ha hecho alguna charla sobre investigación, sobre educación, sobre los derechos sociales y humanos. Bueno, como siempre le gusta trabajar a ALPE desde una perspectiva integral de la persona, no dejarnos ningún ámbito, ningún área que creemos que es realmente importante para el bienestar. Hoy tenemos con nosotros, pues que no, poca presentación casi merece, el doctor Wiliam Mackenzie. Bueno, él es cirujano ortopédico en el Hospital DuPont de Delaware para niños, pero es un referente a nivel mundial en lo que son todas las displasias esqueléticas, ¿no? Nosotros siempre ha participado en todos los congresos internacionales de la Fundación. Aparte de dar esas exposiciones magistrales y aportar todo ese conocimiento que tiene y que su experiencia la avala, es una persona tan cercana, es una persona tan incondicional con los niños y con sus familias. Desprende tanto amor que nosotras desde la Fundación también se lo correspondemos, nos tiene totalmente enamoradas desde el primer minuto que le hemos conocido hace ya muchos años aquí en Gijón. Así que es verdad que él es un gran colaborador de la Fundación, pero nosotras desde la Fundación somos unas incondicionales del doctor Mackenzie. Todas las familias preguntan habitualmente por él, todas las familias le tienen un cariño tremendo, no solo por el conocimiento, vuelvo a repetir, sino por esa cercanía y por esa humanidad que desprende y el trato que da habitualmente con los niños, no solo evidentemente de la Fundación, sino nos consta que en su hospital también. Trabaja con un equipo maravilloso, tenemos que decir que él es un referente estupendo, pero tiene un equipo multidisciplinar en su hospital que es fantástico, que también es referente a nivel mundial. De hecho, la semana pasada tuvimos con nosotros a la doctora Mary Cerú, que fue también fantástica. y que bueno, pues tenemos el lujo de poder contar con él, no solo hoy, sino siempre, siempre que le necesitamos desde la Fundación, que cualquier familia le necesita a través de la Fundación, siempre obtenemos respuesta y eso no tenemos manera de agradecérselo más que así públicamente. Pero hoy tenemos el gusto de contar con él, pero siempre tenemos el lujo de contar con él. Siempre está detrás de ese email, siempre está detrás de ese teléfono y para nosotros eso es un valor incalculable y que bueno, pues cada vez que tenemos la oportunidad de poder decirlo, aunque sea públicamente, pues lo hacemos. Muchísimas gracias, doctor Mackenzie. Es un honor tenerlo hoy aquí en nuestro ciclo de expertos ADE. No podía ser de otra manera, no podía faltar. Y bueno, pues ahora le dejamos todo su tiempo de intervención y luego le retomamos otra vez, si le parece, para un tiempo, aunque sea cortito, de preguntas y respuestas. Cuando quiera.
Wonderful. There we are. Can you see my screen? Yes? Good? All's well. Well, you know, you are so kind to me. You you make me feel embarrassed, but I understand your sentiments. We both feel the same way. We want to view these children and young adults that I care about as whole people, not just for their short stature or a certain deformity. They're people that function in our society, often function extremely well. And my job is to make that as ideal as possible. You've been so kind to me over the years. Myself and my wife, we visited you many times, and we'll look forward to doing that hopefully in the future when things improve. But I've got to talk. It's quite a long talk. Hopefully you don't fall asleep, and also if you need to stop me, just stop me and I can answer a question. That's not a problem. So thank you, ALPE. Thank you for having me. Thank you to all my friends there. And we're going to talk about, firstly, some things that I think are very important when you're talking to your doctor. What do you say? And we're going to talk about achondroplasia. And then we're going to talk about briefly some other problems and a few other dysplasias that I think are important for you to know about. So here's a young family I knew very well. They came originally from Texas, and their child has had many, many surgeries over the years. He's now in university. He's an amazing young guy and doing extremely well. So as a parent or as a young adult, when you're seeing your doctor, is there really a need for surgery? Why am I getting the surgery? Is it to improve pain, improve function, make me taller? It could be anything. But is there really a need for it? And what is the plan? What's the plan preoperatively, intraoperatively, and postoperatively? And how long will it take to recover? Are there any non-surgical options? Consider getting another opinion, but not a third, fourth, and fifth opinion. I can tell you, every doctor you see will have a slightly different opinion, and it will become very, very confusing for most people without a medical background. What are the benefits of the risks and the risks? Do the benefits, ideally in my world, do the benefits outweigh the risks? There's only a few operations that you would do if the risks outweigh the benefits. And ask the surgeon, do you have any information for me to read or look at? And how many surgeries have you done like this before? And have you ever done it on a dwarf? It's important you understand what dysplasia you have and the impact of that diagnosis on the surgical plan. What tests do you need before the surgery? What needs to be explored before the surgery? You heard from Mary Thoreau last week. Anesthesia can have a lot of problems with the intubation, and this can all be figured out beforehand. You don't want to be sitting in a surgery center with no anesthesia backup and have something go wrong. You want to know if there's a chance of neurological injury and any need for neurological monitoring. You want to know if you have any heart or lung problems that would impact the surgery or the recovery. And how long will the recovery take? What do you need to do? And you might be very interested if the surgeon feels that he wants you to be in a rehab unit for several months. So we're going to start with achondroplasia, and we're going to start at the top. At the base of the skull, there's an opening that allows the spinal cord to leave the brain. That is called the foramen magnum, and you see it pointed to by that green arrow. And that green arrow is on the base of the skull of someone with achondroplasia. The skull next door to it is an average stature person. We'll look at the size difference of that canal. Well, that can cause pressure. It is smaller because the problem that causes short stature and achondroplasia also affects the growth at the base of the skull. This is very common in achondroplasia. About 20% of people need to be decompressed, and it's usually at a very young age, usually just around a year is the average. So if this is your baby, you should worry. Do you have a 2-month-old child with apneic episodes where they stop breathing, difficulty swallowing, getting things caught in their throat, and their motor development is slower than expected? And the physical exam demonstrates weakness and problems with the spinal cord. You should be talking to your doctor, and your doctor should understand this is a serious problem, typical in babies with achondroplasia. And that is the foramen magnum stenosis. So here we see it, here we see it here, very tight. And if you decompress it, like happened here, function can return to normal. All you need is to get that area decompressed. It doesn't need to be fused. And the results can be fabulous. This child was not walking at age 3, and a year later, he could walk. The kyphosis that you see in the back in these children is very, very common, usually by 4 to 6 months. It is more pronounced when they're in a propped sitting position, and it typically improves when the child achieves independent ambulation sometime between 2 and 3 years of age. The treatment is controversial. We'll get into braces in a second, but most people advocate avoiding propped sitting while your child is still not able to sit independently. This is data from about 300 children in our institution, where the yellow line is a reduction in the curve in the middle of the back. That usually gets better slowly over childhood, and then there's a small amount that persists into adulthood. When do we consider bracing? Well, first of all, not very often. We did this study where we looked at if you had a severe kyphosis or if it was stiff in an older child with developmental delay and progressive wedging, as you see where the green arrow is pointing, we might consider a brace for that child. There's very limited data for bracing. There's really 2 studies in the literature. This is one of them. And they looked at using a brace in 33 children who got better. Well, surprise, they're expected to get better. So did the brace actually have an effect? Here we can see a child who had no treatment, and you can see that the ankle got better from 3 to 7 years. Well, when do we consider surgically treating this? Well, if it's a big curve, the child's over age 5, has wedging of the vertebra, and in my practice, I want to make sure the child has symptoms of either narrowing of the spinal canal or pain. Okay. So here's an example of a child who was 10 years old and then 16 years old. And you can see that the curve, the thoracolumbar kyphosis, got worse during that age. He also was a hiker and lived in Colorado and was having pain and numbness and tingling and weakness in his legs when he walked. And you can see these are examples of evaluating the area. And the most important one is this one here, which shows the spinal cord is being compressed in the spinal canal. So we had a progressive symptomatic deformity causing spinal cord dysfunction. So we relieved the pressure by decompressing it, realigned the spine, put support in the front, and was able to hold it out straight. And that boy is around 20 now, a little bit older than that, and he is running around and skiing and climbing. This is a boy some of you may recognize. I met this young man years ago in Lyon. He had had multiple previous procedures, and you can see the deformity in his back. This required a huge operation, taking out 2 vertebrae. But today, he is actually on this call, and he is doing beautifully. And he was a lucky boy. This was a big operation with no complications. And I'm glad we were able to achieve it. But what we would like is not having to get this severe. Spinal stenosis is when the spinal cord is compressed because the hole for the spinal cord in the back is not big enough. Now, this can occur all the way from the head to the bottom. Most commonly, we see it in early infancy at the base of the skull, and later on in life in the lumbar area. So that's the lower spine. The most common complaint is something we call neurogenic claudication. And that's when you walk, if you walk a certain distance, your legs get numb and tingly and weak. And you stop and you squat down or sit down, and it gets better, and off you go walking again, and it gets worse and happens again, and you stop, and so on. And over time, that usually becomes more severe. And the problem is, as it becomes more severe, you start to see weakness, which is measurable, and changes in the function of the nerves to the lower extremities. It can also occur in the upper extremities, in the arms. So when that starts to happen, that is important and it needs to be managed. About 25% of kids are symptomatic by 15 years, 60 to 80% in older people. We evaluate it with an MRI usually today. And in this X-ray or this MRI, you can see here, the spinal cord is being compressed behind that vertebra, And here, if we take a cut in this plane, you can see there is no fluid or fat around those neural elements. That is too tight. The treatment is decompression, and we want to get that early. So there's improved results and improved independence. So we treat about 30% of the kids we see. It's more 30 to 40% over the lifetime of the individual. We'll do a decompression. In a child, we also have to instrument and fuse, because if you take the tethers out of the back, you will get a slowly recurring deformity. And so it's very, very important that you have to fuse this. In adults, you only fuse it if you need to support the spine. And it is not a procedure without complication. This shows a young man who I treated a few years ago who had tightness in the spine, in the neck, and the lower lumbar spine. And I needed to decompress and fuse at both levels at the same time. Bow legs, as you all know, are very common. We see it in 75% of individuals with achondroplasia. It's not always progressive, and it's not always symptomatic. Here we see a group of kids playing soccer at Denver at a Dwarf Athletic Association meeting. And if you look really closely, it's hard to see from their shorts, but they all have bow legs and they're all completely functional. We don't know exactly why it occurs. There's some people who think that it's overgrowth of the bone at the side. That's the fibula, the small bone. The tibia is the big bone. There's the knee joint. It's probably related to obesity, too much weight through the knees, and asymmetric growth of the growing zones. Here's a girl who had deformity at multiple levels. She had bowing through the femur, the thigh bone. She had laxity or looseness of the lateral ligaments of the knee. She had bowing of the upper tibia and the lower tibia. This all needs to be addressed for appropriate treatment. When do I consider treatment for bow legs? An increasing deformity, symptomatic loosening of the outer ligaments of the knee pain, and other structural changes in the knee. We do not change the knee to prevent osteoarthritis, because there is not one article in the literature that says that these kids develop arthritis in later life. Here's an example of the current technique of what we call growth modulation. This can be used in children with growth remaining, so it's before puberty. And you can tether the growth on the outer side of the knee, allowing the growth plate on the inner sides of the knee to grow and straighten out the legs. And here we see an example in a 12-year-old, 1 year after what we call growth modulation or 8-plate surgery. And you can see this boy has almost completely corrected. There was a procedure which Steve Kopitz in Baltimore described many, many years ago. He did this in most of his kids with bow legs. The recent literature is not good, but a man called Weiner in Akron did a study and found that it worked in about 2/3 of the children. So I do not do this procedure because it is not as successful as other techniques. Here's an example of a 4-year-old boy with severe geniverum who was really having a lot of pain. Now, I can use growth modulation in this boy, but you can see that technically it would be quite difficult, and he was in a lot of pain. So I straightened him out. I straightened his legs out and also derotated his feet in the same procedure 6 weeks later and then 7 years later. And this is an example of a girl 2 years after her surgery for her bow legs. In older individuals who are already skeletally mature, you can't use growth modulation. And so we have to address the levels of deformity with osteotomies. And this was an example of circular fixators cutting the bone at either end of the tibia, so just below the knee and just above the ankle. And here was the result. You could see a very nice straight leg, both sides. Sometimes knee pain is not caused by deformity. This is a child who had knee pain and clicking. And in this child, there was a tear of the outer meniscus of the knee. So we all have cartilages in our knee, and we know soccer players, football players who damage the meniscus. Well, this is a congenital meniscal or cartilage abnormality, and you can see it right here. This is the bad side compared to the good side. And you can trim that down and make them a lot more comfortable. So when you have a child with knee pain, sometimes it's a simple problem rather than bow-leggedness or a problem with the spine. So extended limb lengthening, very common in Spain. Many of my good friends, Dr. Ginabreda in Barcelona, and other people are talented limb lengtheners, but it is not needed in every single person. Limb lengthening has not shown much difference in function pre and post-op limb lengthening. People do feel much better about themselves. They have better self-esteem, but not necessarily better function. And people do extremely well in their lives using their stature to their advantage. Here we see a young man who was a cox in a rowing boat, and the boy next door who became a bodybuilder. There are many people who have functioned in life a short stature. Growth hormone therapy is not something that is used at this time. It is an insignificant increase of growth of around 3 centimeters for most kids. Limb lengthening should not be used in types of dysplasia where the articular cartilage is abnormal. It is normal in achondroplasia. The current medical therapies that are being looked at in achondroplasia are multiple. There are many companies in the world that are developing therapies for achondroplasia. It is creating a lot of angst in dwarfing communities. And this will still need to be worked out. This is a product that's being developed by BioMarin. It's called Vosoritide. It is a manipulation of a naturally appearing product in our bodies that increases the growth rate of long bones. Well, we know that in achondroplasia, the problem is that the growth of long bones is slowed. This drug is given by daily injection. It's well tolerated. It has a reasonably low complication rate. We don't know what the long-term effects are as yet. The main studies of this drug have shown that the growth velocity of children who are in their growing years is increased over the 4 or 5 year period that's been investigated. So there is suggestion that this may have an impact that will be long lasting on height. This is a typical limb lengthening, something which I don't do anymore, but this was a child that did many, many years ago, 22 centimeters of length. Now that was a long, arduous process for this family. So maybe there may be an impact for those who want lengthening to consider a medical and mechanical lengthening to get a total that is reasonable. And this is something that is being discussed all over the world right now. So I'm going to go over some spine problems and other dysplasias. So upper cervical instability is the one problem we have to look for in every single child with skeletal dysplasia. It is very rare in achondroplasia, but every single other form of skeletal dysplasia needs a flexion extension cervical spine x-ray in the clinic visit. And here we can see that one and first vertebra, second vertebra. Look at the position of the two here and then the two in extension. And you can see there's a lot of motion there. Well, look at what this looks like on a flexion extension MRI. Look at the spinal cord in flexion being compressed and an extension somewhat relieved. This is a very, very important issue with significant scarring in the spinal cord and needs to be treated. This was treated with the decompression and fusion using instrumentation and is probably will allow this girl to function well into her adult life. In diastrophic dysplasia and in multiple other dysplasias, scoliosis is common. It is uncommon in achondroplasia. I'm using diastrophic dysplasia as an example for the other dysplasias, except for one. I'll show you one other. So here's a child at 4 months, pretty straight spine, by 1.5 years starting to get a scoliosis. This was treated in a brace and subsequently in a special cast that we call a derotation cast. We have studied a number of patients with diastrophic dysplasia and demonstrated that casting can help maintain correction and potential lung volume and allow continued growth. But usually treatment is needed in the future. So here's an example of a young lady, the same one with diastrophic dysplasia at age 4 years. Well, it got to the point where casting wasn't effective anymore. So we did a spinal growing rod system. And this is really simple. You grab the top of the spine, you grab the bottom of the spine, and you stretch the spine out and straighten it out. Here she is. Unfortunately, these rods are lightweight and they break and all sorts of things happen. These rods require lengthening every 6 months. So the child has to go through the general anesthetic every 6 months with an impact on brain development, probably. It's psychologically difficult. And there's a high revision rate for all these things that happen. There was some improvement with the new MAGIC, or magnetically controlled growing rods, where we can lengthen them with a device on the outside. There's less infections, less general anesthetics, but the complication rate is actually almost as high as the other types of growing rods. but lower infection. So we're not there yet. And later on, when they're fully grown, they have to get converted to a final fusion. This child presented too old for growing rods and had this significant deformity. And this is an example of the correction you can achieve with instrumentation and fusion. This is a very unique form of skeletal dysplasia that presents with a rapidly progressive kyphoscoliosis. And here you can see a boy with a very severe deformity, a boy from Poland I treated. And we released the tight structures in the chest with the scope and hung the child in traction. Here's an example of a girl walking outside at our facility in traction. And this is that boy from Poland, and you can see how dramatically the improvement was. He has since gone on to a final fusion and doing well. I just wanted to talk a little bit about our research into growth modulation, which is using those 8 plates to control deformity. So here's an example of a boy with knock knees that was converted to straight legs with the 8 plates. Well, the problem in skeletal dysplasia that's different to average stature children is they grow slower and they're shorter. The deformities are often a lot worse. There is usually associated other deformities around the joint and much earlier onset. And so when we use these techniques of growth modulation, you often may need repeated procedures. You may do it for a couple of years and then come back 3 years later and have to do some more. And this is that example I just showed you. This is probably the most important message I have for you. This is the group. I just took this picture a month or 2 ago, and it shows not, maybe 2/3 of the group we work with. It is extremely important to think all of these kids through from multiple perspectives. Physical therapy, pulmonary, anesthesia, neurosurgery, orthopedics, the gamut. Because if you don't think about it carefully, you're going to make a mistake. Our goal is to optimize, at least the orthopedic goal, is to correct deformity, to reduce pain, and prevent future limitations. Not to just make them straight, because the orthopedic surgeon likes straight people. This is where I come from. I will not even attempt to say that in Spanish, but for the amount of visits that I've had to Spain, I should be a better speaker of Spanish, and I apologize for not being. Thank you. I hope that wasn't too much information at once.
Bueno, como siempre, nada, siempre es poca la información que nos da, doctor. Siempre nos quedamos con muchísimas más ganas de escucharlo permanentemente. Estaríamos toda la tarde escuchándole. O sea que no tenga ningún problema en pensar que...
Believe me, I know, because I get about 2 hours sleep when I visit ALPE. I'm either working or drinking sidra.
En ALPE hay una gran combinación entre el conocimiento y la diversión, que siempre va unido, porque además sí que es verdad que además siempre da conocimiento a todas horas, no solo en el momento de la charla y de la exposición, sino que también invierte su tiempo personal en visitar a niños, en pasar consultas con niños, y por la noche también de fiesta también imparte lecciones magistrales. ¿Eso es verdad? Así que
Well,
estamos
I
felices.
appreciate the chance to talking to everyone and seeing quite a few of my friends. I now have my son working for me, so he can take over in the future and come and spend time with you.
Bueno, yo creo que en el próximo Congreso Internacional, que va a ser el año que viene, crucemos los dedos, su hijo estará invitado también a participar, porque tiene que coger el testigo de su padre de una manera progresiva, pero a tope. Por lo menos nosotros ya sabe que todo el que se acerca a ALPE siempre le recogemos bienvenido y no le dejamos escapar.
I appreciate that. It's always a wonderful visit.
Si le parece, tenemos unos minutos para poder hacer algunas preguntas que nos han dejado los asistentes en diferentes chats.
Absolutely.
Muy bien. Mira, pues tenemos alguna como, preguntan si las caídas en los niños puede ser un síntoma de una estenosis baja.
Well, you have to be careful about that because toddlers with achondroplasia and many forms of skeletal dysplasia trip and fall normally. And I always joke that they don't have far to fall. So, you know, I think that occasionally you may see a young child with weakness that causes falling, but most of the time it's just toddlers falling. So you have to be very careful because I have seen very, very young children, 2- and 3-year-olds with achondroplasia that have come to see me because their doctor told them they need to be decompressed for spinal stenosis. And very, very rarely is that required. So I think you have to be really, if there is a child under age 10 with achondroplasia that needs a decompression, it needs to be reviewed by someone else and very carefully considered. But yes, it can be caused by weakness.
Gracias. Otra pregunta es si a cualquier edad puede existir riesgo de estrechamiento del foramen magnum. ¿O hay una edad más crítica para ello?
The foramen magnum does not get narrower with age. So the foramen magnum gets wider over the first half decade to decade. So the foramen magnum usually gets progressively wider during infancy. The only time that an adult might need decompression is if it was missed earlier in life. It's very uncommon to have a normal foramen magnum and then require decompression later.
Muy bien. Tenemos otra pregunta aquí sobre la edad en la que pueden aparecer las deformidades del gen ovarum. Si hay alguna edad también crítica en la que empiezan a aparecer esas deformidades.
It's highly variable. We see it in infants, and sometimes we don't see it at all. Matter of fact, we have some kids, a very small percent, that have knock knees, so-called genuvalgum, the opposite. So genuvarum is highly variable, very variable in how symptomatic or progressive it is. And it is something that each individual child has to be watched. You can't give broad treatment plans. you want to only treat the kids that are progressive and symptomatic.
Muy bien. Hay otra pregunta que una mamá dice que al escucharlo en la exposición, parece ser que dice que en la mayoría de los casos usted recomienda no recomienda usar como una prótesis ortopédica, un corsé, ¿no? Para tratar de corregir la cifosis. Que simplemente esperar hasta que el niño tenga 5 años y ver que vaya mejorando por sí solo, asumiendo que no haya síntomas que requieran otro tipo de cosas. ¿Es así? O quizás lo haya entendido mal.
I think that's it. Yes. Yes, generally that's true. If you have a child who is very, very slow to develop, not walking at age 2 or 3, has significant cognitive issues with a big stiff kyphosis with wedging of the apical vertebra, I would brace that child. For a child with the flexible thoracolumbar kyphosis that is starting to walk by age 2, I would not treat that child. And the problem is the studies that promote using the brace do not have what we call a control group, which is a group of kids the same age with the same deformities and followed without bracing. You know, if we know the natural history and the majority of them is get better and you use a brace, well, then you just say they all got better and the brace works. But we know it's not always needed. So do I never brace? No, I do brace once in a while.
Sí que nos pasa en España también el tema de utilizar enseguida las prótesis. Bueno, nosotros estábamos viendo que sería importante hacer un estudio profundo ahí, ¿no? Porque vemos que hay veces que con un buen trabajo de fisioterapia, con un buen trabajo de potenciar la musculatura, se evitarían a veces poner esas prótesis que muchas veces traen más efectos secundarios que realmente lo que en teoría se intenta corregir. La verdad es que es realmente interesante, sí que habría que ser un tema de estudio en profundidad. Hay otra pregunta.
Yes.
Una mamá que dice que ¿hasta qué edad considera usted que es eficaz el crecimiento guiado, ¿no? Ella tiene un niño de 13 años y su cirujano ortopédico quiere trabajarle un crecimiento guiado. No tiene unas cirugías previas y tampoco aporta dolor. Si usted lo vería aconsejable.
No. So so there's two questions there. The child has no pain and normal function. Does the child have normal function? Maybe the mother could answer.
Steph, a ver si nos puede responder Steph.
Okay, well, that's fine. So
sí lo hace, sí camina bien, sí.
Functions normal. So in that case, it's probably quite mild. And, you know, I don't know without seeing him. I don't think it's a very rare event that I treat a child who has no pain and no severe deformity. So, but the other question is, in a 14-year-old, is there enough growth remaining at the knee to get correction? That is getting very, very close to the age where there probably will not be any impact. So in a 12 or a 13-year-old, I probably consider it. In a 14 or a 15-year-old, depending how old they are, and you can look at their bone age, you can take an x-ray of their wrist and hand and see how much growth is remaining. But if they are going through puberty and their growth and height is starting to tail off, I think it's probably not worth it.
Gracias, doctor. Hay otra mamá que dice, nos ha llamado la atención la referencia que ha hecho sobre la artrosis en niños con achondroplasia. Pues siempre hemos oído que ante sus deformidades se prevé que tengan artrosis precoz e incluso recomendación de alinear los miembros lo antes posible para evitar dicha artrosis precoz.
Okay, so is there one person with achondroplasia in this group listening that have, or do they know anyone who has had a total knee replacement? I know a couple. I know a few people who've had knee replacements, but it is a rare event. And tell me, how common are bow legs? Everyone has bow legs, right? Pretty well. So I think that answers it for you. So people, orthopedic surgeons are used to treating average stature people. So if I am average stature and I have a bow leg, we know that by the time I'm 50, I'm long past 50, by the way, by the time we reach 50, I will need a knee replacement. So that is true of average stature people. But as far as we can see, it is not true in achondroplasia. But again, it's another area that needs to be studied. But for those of us who have followed thousands of kids with achondroplasia, it's a rare event getting a total knee replacement. Although it does occur every once in a while. Usually people who are very involved in sports, actually.
Muchas gracias. Hay una pregunta ahora desde otro profesional, desde otro doctor en Argentina, que dice, la modulación de crecimiento en la achondroplasia no nos funciona bien por encima de los 6 años. ¿A usted también le ocurre lo mismo?
16? No. I don't know what the experience of that surgeon is. It might be someone I know. If it is, hello. But growth modulation does work in achondroplasia. I initially, early in my career, I was not a believer in growth modulation, but I have so many cases where it works now. It doesn't work in really severe genuvarum, and it doesn't work the closer you get to skeletal maturity. But in a 6-year-old, it should work. I rarely just do the proximal tibia. I usually do the distal femur and the proximal tibia and fibula. And now, most recently, I've been using an 8-plate in the distal tibia as well. And you know what? It works. It does work. And I'm sure there's a reason why in your case it didn't work.
Muy bien. Ahora le preguntan sobre una pequeña pregunta sobre investigación. Ya que participan los estudios de Biomarín, de Orthopaedic, preguntan si en estos años han visto una mejoría en las proporciones de los pacientes, no solo en el crecimiento, sino en la proporcionalidad.
Well,
una pregunta del
you know, I'm on a Biomarin advisory group, and we are part of the study here. We have different types of the study here. It's managed by Mike Boberg, who's the geneticist I work with. You know, it looks like there is a slight impact on proportion. It is not clear, and it is not proven yet, but the it looks as if there is some support that if started early in life, it will have an effect on proportion.
Hay otra familia que no le ha quedado claro si al final es conveniente o no es conveniente la elongación, la cirugía de elongación. Eso es un poco complicado también de
So
responder.
the
entendemos.
only person that can answer that question is the child and the family. You know, I am not here to tell people what to do, right? I'll advise someone pretty firmly, but lengthening is a long process. The results in experts' hands are reasonable with low complication rate, but it should be the child and the parent's decision. And it's not for everybody. Just because you're short doesn't mean you can't be a functional person. I'm seeing a question from an old friend of mine called Joe Foose, who lives in San Francisco. He has a wife, and you all know
está
Joe
haciendo sí, ha hecho varias.
Yeah.
Sí.
And
Sí.
you remember they're the ones screaming and throwing things from the back during the lengthening talks. And Joe asked me a question on the chat function here. So he said, your medical vocabulary is wonderful for professionals, but we get lost as lay people. So he said questions like distal tibia, femur, 8 plates. So why don't we, let me share the screen and I'll just go over that. I thought I was trying to go slow, but I apologize.
No, yo tengo que decirle algo a favor. Es un vocabulario muy accesible a las familias y a las personas. Están bastante familiarizados con esa terminología básica. Si quizás fuésemos a más, pero esa terminología básica yo creo que sí, que siempre es bastante comprensible por parte de las familias. Ahí puede estar bastante tranquilo. Pero si quiere compartir pantalla y explicar algo en concreto.
Well, I'll show it for the English people, okay? Except I don't seem to be able to share my screen now. There we are.
Quizás.
There, I found it. Okay. It'll take me 10 seconds. All right, here you go. So there's the lower extremities of someone with achondroplasia. The femur, the tibia. Proximal means closest to the middle of the body. So that is the proximal tibia. That is the distal tibia. There's the distal femur, the proximal femur. And these are 8 plates. And they're called 8 plates because I think when Peter Stevens invented these, or one of the people who invented them, it looks like an 8. So I can show you why in a second. But if you look at these plates, there is a short plate and a screw going on one side of the growth plate and on the other side of the growth plate. It tethers the growth there and allows the growth there. So here we see it from the lateral position. So you could imagine without those screws in there, that plate looks like a metal 8, and that's why. There we go. Joe, did you get it?
Sí.
Muchas gracias.
Dice sí en español, sí.
Yeah, he speaks Spanish, right? He's talking for
Sí,
the
lo sabemos.
non-Spanish speakers.
Fantástico, muchísimas gracias. ¿Tenemos algún minuto para hacer alguna otra pregunta, doctor?
Sure, sure, sure.
Muy bien. Hay una mamá que pregunta, en niños que han sido operados de descomprensión del foramen magnum, la aparición de un melanoma, ¿qué puede significar?
Melanoma?
Es
Melanoma
lo
is a
que pone, no
cancer.
sé sí, no sé tampoco qué referencia, qué relación puede llegar a tener. No sé si la mamá nos quiere escribir matizando un poquito esta pregunta. Vamos a esperar si hace alguna
Well, maybe,
algún
yes,
matiz
maybe
más,
you could try and, what did he say?
porque sí, a mí también me sorprendió, la verdad. Mm, mm. A ver si nos da algún dato más. Una mamá que pregunta, mi hija tiene 4
Okay.
años y aún no camina. Le han puesto un corsé para corregir la cifosis, pero parece que no tiene rigidez en la columna. ¿Cree que hay que preocuparse porque no camine todavía estos 4 años?
How
No
big is
presenta
the
rigidez en la
kyphosis?
columna.
What is the number? Does the mom know the number?
Mm. Bueno, yo creo que este tipo de preguntas, que requieren más datos, evidentemente, quizás nos las pueden enviar al email de la fundación.
So not walking,
Sí.
yes?
No camina todavía con 4 años, es lo que pone la pregunta, pero yo creo también, como usted,
Okay.
que faltan
So
datos para poder dar una buena respuesta.
not walking is actually by age 4 is well outside the normal developmental motor milestones. So that needs to be looked at. And if the child has not had an MRI, it probably needs an MRI at the base of the skull. There are other reasons for it as well, but if the child is cognitively developing well, like interacts with the parents and uses some words, and if there is weakness that doesn't allow walking, that needs to be investigated.
Bueno, yo creo que bueno, le da muchísimos recuerdos la doctora Virginia Fano y las gracias por la intervención. Aprovechamos que está aquí también una doctora del nivel de Virginia Fano, desde
there's
Argentina.
someone more famous than I.
Es otra colaboradora
Dr.
también de la
Fano and
Fundación
I have
maravillosa.
known each other for a long time. She's in Buenos Aires, and when I was down there, I visited her. We actually gave some talks together in a presentation. It was fun.
Bueno, yo creo que podemos hacer una última pregunta y si le parece, el resto de las dudas que hayan quedado las pueden dirigir al correo de la Fundación y se las hacemos llegar vía email para que pueda contestarlas con calma y tampoco ninguna familia se quede o ningún profesional se quede con la duda. ¿Le parece que lo podemos hacer así? Para no quitarle más tiempo también a usted. Le hago entonces la última pregunta. Mira, una mamá que pregunta si es un síntoma de descompresión, o sea, de que hay un problema en el foramen magnum, si un bebé de 3 meses deja de respirar 3 o 4 segundos. También hace distintos sonidos al dormir y respira con algo de dificultad en general. Sin embargo, fue monitoreado por 3 días y estaba bien oxigenado, entraba bien el oxígeno, pero si esos síntomas pueden ser también de necesidad de una descompresión.
So, so more important than the oxygen levels, obviously the oxygen levels are important, but more important, it's periods of what are called central apnea. So kids with achondroplasia have 2 types of apnea. They have obstructive apnea, which is very common even in adults. And it's because of the small airway at the back of the throat. It's called the nasopharynx. If that airway is small in a little child, a normal sized tonsil and adenoids can block the airway. And that's why lots of kids get adenoidectomy and tonsillectomy. But the central apnea is caused by compression of the spinal cord and the brain stem at the foramen magnum. That causes and can be seen in a sleep study as different from central apnea. And so it's not just one thing to monitor the oxygen saturation. It's important to look at other aspects of the breathing. But I would think if your child has had periods of significant apnea, the child needs an MRI to evaluate the brainstem.
Muy bien. Mira, hay un matiz a la mamá que no era un melanoma, se refería como a una cicatriz, que le había quedado una cicatriz después de la descompresión. Que si es algo significativo, que le quede una cicatriz, la médula.
Well,
no sé si eso le sirve.
So there's a really interesting thing with achondroplasia. If you were to MRI all adults with achondroplasia, whether they had surgery or not for the foramen magnum, there would be a very high incidence of some scarring in the spinal cord in the upper cervical spine. We think that may be related to some tightness and a little instability in early life. It doesn't seem to cause too much problem, but also surgery for foramen magnum stenosis can be very, very difficult. It can be extremely tight, and you have to be a good neurosurgeon to do it without damage. And sometimes it's so difficult, even those that are good at it can end up with spinal cord damage. So I'm not sure what type of scarring your child had, but sometimes it's just because it was very, very bad and difficult surgery, or it just may be that it's there because we see it quite commonly in older people.
Muy bien, pues yo creo que nosotros no queremos robarle más tiempo, doctor. Las preguntas que queden, bueno, pueden hacérnoslas a través del correo de la Fundación y nosotros se las hacemos llegar. Y nada más, darle infinitas gracias por su tiempo, por esta presentación tan magistral como siempre, que nos tiene tan bien y mal acostumbrados. Y bueno, le emplazamos a verle en nuestro próximo Congreso Internacional el año que viene con su mujer y en este caso con su hijo también, que contamos con los tres. Pero antes seguro que tenemos las opciones de volver a conectar con usted y con todo su equipo para seguir, bueno, pues en este proyecto de intentar divulgar ese conocimiento y hacerlo llegar a todas las personas que lo necesiten, niños, adultos, profesionales, familias, que tan importantes para todos. Así que muchísimas gracias y tengan unas felices vacaciones de Pascua.
Thank you. Happy Easter to everyone. Hello to all my friends around the world. And thank you so much for including us. We really enjoy the relationship.
Nosotras también, un placer. Muchísimas gracias.
Bye bye.
Besos desde España.